Good afternoon to all of you on the East Coast, and good morning. If you are on the West Coast, my name is Dr. Jose Leon, Clinical Quality Manager for the National Center for Health and Public Housing, a project of North American Management. I want to welcome and thank you all for attending today's webinar, Changes to Board Governance, HRSA PIN 2014-01, Health Center Program Governance. This webinar is being recorded, and the resources, slides, and other materials will be emailed to you after the webinar has finished. At the end of the webinar, there will be a question and answer session. And I'd like to get started and introduce our speaker. Our speaker is Ms. Allison Dubois. She is the Chief Operating Officer for Hudson River Healthcare. Ms. Allison Dubois has extensive experience in and committed to public health. She is currently responsible for all Hudson River Healthcare administration, including contracting, grants management, outreach implementation, special populations, community relationships with the special service providers, as well as hospitals and other community health centers, and legislative advocacy. As the former Director of Government Affairs and a Special Project for the Community Healthcare Association of New York, Ms. Dubois has broad experience in advocacy and policy making on behalf of community health centers. She has a Master's of Public Health from the Mailman School of Public Health at Columbia University and received her bachelor's degree from Cornell University with a concentration in gerontology. She was the 2010 National Emerging Leader Award winner from the Geiger-Gibson Center for Community Health, George Washington University. In 2011, Ms. Dubois completed the Johnson & Johnson Healthcare Executive Program at UCLA Anderson School of Management. I'm now turning the presentation over to Ms. Allison Dubois. Good afternoon.
Good afternoon, everyone. I'm so pleased to be here. I appreciate the opportunity. Can you just confirm that you've got my slides up? Everyone can see that?
Yes, we can see them.
Okay, great. So thank you so much for that introduction. It's always painful to listen to those descriptions, but I'm very happy to be here and have been involved with Hudson River Healthcare's public housing program for many years, and pleased to have this opportunity to talk about governance. I thought I would just start with a bit of additional information about Hudson River Healthcare in the context of our public housing program. And again, our Hudson River Healthcare was founded by our four founding mothers, as we like to describe them. These are four African-American women from the Peekskill community who were really struggling with access and traveling significant distances with their families in order to be able to access care. And so they worked in partnership with other health centers to establish our flagship health center here in Peekskill and 40 years ago. So we're actually celebrating our 40th anniversary. Our mission is to increase access to primary and preventive health care and to improve the health status of our community, especially for the underserved and vulnerable. Hudson River Healthcare now has 24 directly operated health centers and 24 directly operated health centers, and we also are in collaboration with FQHC in support of them as a subrecipient with the operation of 5 health centers in Nassau County. In this current year, we are looking forward to 2015 to have over 110,000 patients throughout our system of care. So Hudson River Healthcare is fortunate to have a number of special populations served within our system of care, including public housing residents, as well as individuals who are homeless or at risk of homelessness, migrant and seasonal farm workers. We also receive dedicated Ryan White funding and are in care of veterans as well as a part of the network. So in preparation and in thinking about the topic for today's webinar, I was really thinking about overall the concept of good governance and how health centers, in particular with the guidance from the Bureau of Primary Health Care, are responding to the concepts of good governance. And so thinking about how those bodies work through consensus, participatory nature, that they're following the rules of law. And so we certainly have a number of BPHC compliance issues that we need to look at, that they are effective and efficient, equitable and inclusive. And I think health centers really, truly have raised the bar on that measure by having the patient participation and our Consumer Board of Governors. That their governance system is responsive and transparent and accountable. And I think that, again, the establishment of a patient board of directors is such an important part of transparency, responsiveness, and accountability because of that very tight connection that we have to the communities that we serve. So the governance PIN 2014-01 was issued on January 27th in 14. It's very similar to the draft that the Bureau had circulated a few years prior, and it replaces earlier guidance. One key point that a number of folks have made is that it is a consolidation of key Bureau guidance around governance issues. And while it serves as a primary guidance, it is not the sole source of information. And so it is important to remember that there are other resources that the Bureau may use as it evaluates the governance components. Governing boards at FQHCs, again, in light of the renewed focus and the reissuance on the part of the Bureau of the 19 standards and the OSV guidance for site visits, it's particularly important, I think, to focus on the elements of the 19 standards that are related to board authority. Again, the overarching umbrella here is that the board assumes full authority and oversight responsibility for the health center, and that specifically the board authority needs to include the key elements that are delineated in the standards around hiring and evaluating the CEO, approving site services and hours, the monthly requirement, which was further clarified in this guidance, approval of the grant submission, annual budget and audit, the sliding fee scale, which, again, I hope most folks on this call know that there is new, much more specific guidance on sliding fee scale. The board also has responsibilities around approving organizational policies, clearly to represent the voice of the patient, monitoring organizational performance, and the development of the strategic plan. The number 18 standard as a part of those governing as a part of those 19 standards is around the board composition, which we're going to talk a little bit more about, and conflicts of interest. The other key areas of input for patient board members that I think are important as it relates to those 19 standards are around the needs assessment. Again, the role of the board in assuring that there is sufficient focus on the special populations and the unique barriers that are faced by those special populations, and in particular by those residents of public housing. Again, on the scope of service requirement, the board's perspective on looking at whether the scope is appropriate for the special population and whether there are any unique program needs that need to be considered. So, for example, as I think about Hudson River Healthcare, the board's perspective on the operating hours and the location for our public housing program were very important to ensure accessibility. This is particularly important as we have this evolution and there are fewer high-density high-rises and moves more towards integration into larger communities. That location and the service delivery are such important pieces to have feedback about. The collaborative relationships component of the board scope is important as well around thinking. I think that our board members provide such guidance around opportunities for collaboration and door openers to faith communities, to housing authority connections, and to those individuals who can really help ensure and support the success of the health center. And I've already talked about hours and locations. The guidance re-articulates appropriate representation, and as a group, patient members of the board must reasonably represent the individuals who are served by the health center in terms of race, ethnicity, and sex. Health centers are also encouraged to consider patient member representation in terms of other factors such as socioeconomic status, age, and other relevant demographic factors. And so I think I'm just wanting to highlight that there was a change in the PIN language from community member of the board to patient member of the board. And so this is an important clarification as it relates to the fact that our patients move. Again, as we think about the changes in public housing, this is a really important consideration that the patients need not necessarily have as close a proximity if they're representing the patients. And so if our patients' addresses are changing, it doesn't necessarily change their ability to represent us well and to represent the patients well. And again, this particular guidance within the PIN around special population saying and clarifying that there must be at least one board member that is a representative of each of the special populations for which the health center receives Section 330 funding. And so, this is, again, I think an important piece as we think about being special population grantees, about how we identify and encourage and engage those special population representatives. Again, this is not a preclusion that you can only have one. There's always an opportunity to have more residents of public housing or of any of the special populations participate in the board, but this is really just the minimum requirement. The guidance further articulates that patient representatives, patient representation is best achieved through patients who are members of the special population. However, they do allow for advocates who have experienced personally being a member of the population. So this is an interesting piece. Again, I think that this often happens with individuals who are homeless, and for those special population grantees or for those serving migrant and seasonal farm workers, the Bureau's standard does need to be that that we've made every effort to engage directly those patients. And I think for public housing, we're really able to do that, I think, in a unique way because of the proximity of our public housing health centers to our patient population can make this somewhat easier in a relative way to achieve than for some of the other special populations. The PIN also provides some key clarifications, particularly around the definition of a patient. And so that now includes this clarification of a current patient with an in-scope visit within the last 24 months. Again, requiring us, I think, to be very thoughtful and to be monitoring this on a regular basis, to look at that 24-month window that does move over time, or the legal guardian of a dependent child or adult who is a patient. The requirement that it is a billable visit is also a different clarification. So a dental patient is appropriate, a podiatry patient is appropriate, and so as long as it meets the standard of a billable visit with a medical provider or a dental provider or behavioral health provider, it does meet that standard. The PIN further clarifies that non-patient board members do not have to reflect the specific expertise in all the areas listed. I think as folks read the PIN and try to think about the size of their board and whether they've covered all of those bullets, it often was challenging having individuals cover all of the focus areas around finance and managed care and other healthcare providers and still meet the special population requirements and also not have a board of 35 people. So I think it was helpful to understand that those were guidelines and recommendations, but not a requirement. This PIN further clarifies some other key points. It eliminates the ability to waive the monthly meeting requirement. Apparently the feedback from some site visits had been, well, we meet monthly, but we take the summer off. Or we meet monthly, but December with the holidays, we don't schedule a meeting. So this was an important clarification that monthly means monthly, and so we do need to establish and keep 12 monthly board meetings. Again, it clarifies the 51% consumer requirement, but I think this is so interesting. It clarifies that HRSA will provide stricter scrutiny. So the fact that that was written into that language around stricter scrutiny and there was further clarification of the patient, I think certainly means that this will be an area of focus and an area that is a key part of review. It continues the limited involvement of third parties in board composition and decision making. So again, as we are in a very complex healthcare environment, and I know particularly for Hudson River Healthcare in New York, there's a lot of consolidations and there's affiliations of our hospital partners and others who are responding to those market trends. But the PIN provides a lot of important clarity about the limit and how the role of third parties in board composition needs to be really defined and limited, because it is the role of the board and it is a consumer patient board that has the ultimate decision-making authority. This PIN provides, again, a lot of information about the relationship for public entities, roles and responsibility clarification, the fact that in the establishment of a public entity grantee, where there is a co-applicant or even with a public entity directly, that they may not override the final approvals and decision-making of the co-applicant board. I think this is, again, important consideration. The co-applicant creation is the ultimate decision maker. That is where the patient's representation sits. And so really having firm regulatory guidance on the role of the co-applicant board and how the ultimate authority remains there. And it requires that a co-applicant agreement and a co-applicant board bylaws be two separate documents, and that those are all presented to HRSA. And then it really just pulls forward the requirement that applies to all FQHC boards forward into the co-applicant public entity arrangement, that no employee or immediate family member of an employee of the public entity may serve on the co-applicant board. Again, really trying to preserve the integrity and the role of the co-applicant board and bringing forward those historic prohibitions into that structure. Around there's, again, more information around co-applicant board requirements. Defining a health center funded, again, just to be clear, a co-applicant is a health center funded through a 330 grant to a public agency. It does clarify that those co-applicant public agency arrangements must comply with all health center requirements and regulations, that this structure allows for access, and it certainly can accommodate the needs within a community, but the structure does not in any way negate the overarching FQHC requirements and regulations. Public centers can be created in two different ways. There's one where a public agency can independently meet all the governance requirements, but the more common arrangement is that there's a co-applicant and a public agency together that meet all the health center program requirements, and this is where the co-applicant guidelines becomes so crucial, because that really is a collaborative relationship between the co-applicant board and the public agency in order to provide services and provide all of the regulatory and structural elements as well as the patient representation. So again, it was, there's a couple of slides here about this, because the PIN was so very clear that the co-applicant board is the patient community-based governing board that sets the health policy. And it will not, that there needs to be a clear delineation within those co-applicant agreements that it is not possible for the public agency to overrule the final approvals of the board, that there is true strength and decision-making authority that is kept within that co-applicant board structure, and that it is together, those two pieces, that HRSA would define as the health center. So additional support and clarification around the encouragement of co-applicant to be formally incorporated, and the requiring the execution and submission of those agreements, and clarity of the delegation of authority and defined roles in those agreements. There's a further discussion around waivers of governance. So those entities that are eligible for a waiver would be health centers or lookalikes who are serving sparsely populated rural areas, or a special population grantee that does not have Section 330E funding. Important to note that a waiver is only good for the project period, and so that waiver would need to be requested again for any, at the point in time that you had a budget period renewal and have to be reestablished by the Bureau for that next project period. And so this is where, there's greater scrutiny. In an earlier slide, we talked about the higher level of scrutiny that HRSA would be looking at, and that as it relates to waiver decisions, that an applicant for a waiver must show good cause or unique or innate characteristics of health center patients or service areas that impose an undue hardship or a significant barrier to establishing the 51% consumer board. So again, this is just ratcheting up the requirement for in what circumstances a waiver would be considered. And I think this is an important consideration for public housing grantees, because again, I think that there seems to be greater flexibility. Our experience in Hudson River Healthcare has been that the participation of public housing board members has not had as many barriers, for example, as individuals who are homeless or at risk of homelessness. So you need to be pretty rigorous in your evaluation of whether you meet that standard of unique, innate characteristics that impose an undue hardship. There are, again, in consideration of a waiver would be the health center's efforts to review alternative mechanisms for complying. We must ensure the standard, the expectation really, is to ensure patient input and participation, and if that can't happen through board representation, what are the other avenues, strategies that the health center could articulate to demonstrate a good faith effort to meet that requirement? The use of advisory councils, what are the types of ways that they get patient input? What is your process for community input to the board? And so how are you gathering that feedback? And then also, how is the board receiving that, digesting it, taking actions based on that? Some of the options that were proposed in the PIN were that perhaps you had a substantial but not a majority of patients on the board. And so if your board was a 12 or a member board, and you could secure and have active participation of 5 patient representatives, but you couldn't meet the 7, that would certainly demonstrate a good faith effort that could be considered for a waiver. Again, the use of advisory councils. This is something Hudson River Healthcare has had a lot of experience with, the development and sustaining advisory councils as a way to augment, our existing patient representation on the board, but it also could be considered for consideration in a waiver application. Advisory councils, as I said, certainly any of these strategies can augment, when you have met the criteria. Advisory councils can provide just a tremendous amount of impact, and some communities have been using the term advisory board, but we think that at least our experience has been the use of the term council clarifies the difference between the expectations of a council versus that of our board of directors. Again, using our advocate board members and focus groups. So these are, again, some strategies that could be considered if there was a request for a submission of a waiver. So this is really a lot more about Hudson River Healthcare, and as I thought about this presentation and what were some of the challenges over time that we had experienced, is that and one of the things I think to help ensure that you have a strong and active board and that you're able to retain the special population representatives and patient representatives on the board is the establishment of meaningful roles for those board members. Certainly their role in the board meetings is critically important, and they have a tremendous responsibility in terms of what they do need to be involved in approving. But their role beyond those meetings in terms of participating in focus groups and other strategies has certainly been something we continue to try to improve on. Health centers are growing larger. I think there are about 1,200 health center grantees, but we have over 9,000 sites. So Hudson River Healthcare isn't the only health center who struggles with the geographic distribution that impacts participation in the board. So as you serve larger and larger geographies and you have multiple health centers, maintaining a good geographic representation, again, meeting all those public housing participation standards or special population participation standards, it's really those things become challenging when you're dealing with a larger geography. And also there are different issues with public housing in one community versus another, and if you have a single public housing representative, are they able to articulate all of the particular needs across multiple communities, or are they really speaking just about the experience in their particular community? And then, thinking about the impact of redefining public housing in our communities, both by the work that is happening on housing authorities, as well as, interesting new guidance from the UDS about what defines a health center in serving public housing residents. I think that these are considerations that we've certainly been spending a lot of time talking about here at Hudson River Healthcare. In thinking about the role for consumer board members and thinking about how to ensure that those are active and meaningful roles, how we think about the role of patients and patient engagement. And so the training and support provided to our patient board members to enable them to engage patients and link them to the health center. Do they have the right materials? Do they have the right language? Are they communicating the correct information about our slide in a way that that's meaningful? Their role acting as a community liaison and representative for the organization. Their participation in advocacy days, both in state capitals as well as in Washington and locally. I think we've really benefited from the local connections of our board members to local politicians as we work through issues as mundane as, traffic for a renovation project, and we need the municipality to be involved and utilizing board member relationships to help facilitate that, to as significant as board members speaking about their role as a patient to our elected officials in Congress when we participate in the NAC P&I. The role of board members as chairpeople of advisory council. So we currently have some patient board members who both sit as a Hudson River Healthcare board member, but also serve as the chair for the local advisory council. And so, that's a tremendous commitment on their part to both participate in our monthly meetings as well as the every other monthly meetings that the advisory council hosts. And so their role in gathering even more substantial patient feedback from the other advisory council members and then being a voice for that on the larger board of directors. Again, this has been a really valuable strategy for us at Hudson River Healthcare in trying to serve such a significant geography. The role of board members as health promoters and patient advocates. Again, thinking about the supplies that we provide to those board members, ensuring that they have outreach cards and promotional materials. They have information about upcoming events that are happening at the health center. This is something we hope to be good at and we always can be better about, so that they are well equipped to be talking about the health centers. I know our experience has been that still in our communities, health centers can be a well-kept secret, and the role of board members in helping to make sure that we have broad understanding of the role of the health center and the services that we provide. Having them participate in focus groups and facilitating those focus groups. In addition to patient surveys, we've utilized a focus group methodology to really get richer and very nuanced information from our patients about their experiences and about the things that they need and would prefer. And having board members participate in that, facilitate that again as patients themselves, has been a really exciting thing to see and has really provided some wonderful opportunities to enhance the voice of our patient representatives. The resident councils in some of our public housing complexes, and the fact that a board member is a liaison to that, that is another avenue of certainly hearing the feedback of priorities from the residents of public housing and getting that information to our board of directors so that we can respond to that appropriately. It has been a terrific connection point for us, and again, is a way of helping to ensure that you've got good feedback. Again, if you're working with multiple complexes or a larger geography or different communities, being able to gather the input from resident councils and feed that back to the board. And we've also been tremendously fortunate to be able to tap into our public housing patient representatives to be a liaison to faith-based community connections, to help open the doors to new programming and new opportunities, helping to schedule events for us in those churches and with those congregations has been a terrific resource for us. And this is a slide that we use to talk about community engagement and population management. And again, I think the consumer board members are so critical to all pieces of community engagement and population management. And as we prepare for the world and the evolution of health centers and healthcare in general, and its incorporation of thinking about entire communities, thinking about the triple aim, there is certainly an opportunity for us to be involved in the health of our overall community, those patients who are coming in the door, those who used to come and haven't been in a while, or those who have not yet come into the health center. These are all aspects of work that we're looking at and thinking about the role of board members to participate in. Again, informing, helping individuals to know about the health center, and then making sure that they know about the health center at a point of time when they're most in need of that. Facilitating, giving us feedback. The patient portal isn't easy enough. The after-hours call coverage didn't work the way I wanted it to work. This feedback from those patients about how they're able to connect and what needs to be improved is so valuable to us. And then steering patients back into a system. So this is something, again, utilizing board members and other advocates to steer patients back in to a system for preventive care has been a really important role and piece that we've looked to board members to be able to do for us. Care management, again, one of the things that as we think about roles for board members, the care management pieces for health promotion, this is the graphic that we use to represent the very multifaceted way that we are striving to care for our patients. And by putting the patient in the center, we then provide these wraparound services in support of that. And we've certainly tapped into the role of board members to focus on health promotion and to give us feedback about how these components of our system are working. And then the patient experience, again, has been woven through all of these pieces that we've been talking about today, both the structured mechanisms of patient experience surveys, but also focus groups, utilizing board members in our health centers to educate patients about why their feedback is so important, encouraging them to fill out those CAP surveys. These have been some things that we've worked with board members to help us with as well. We've also been really tied and having some very important conversations with our patient board members around behavioral health and primary care integration. And their feedback has been really valuable about the need for us to move from this current coordinated co-location to really integrated services. And the experience of our patients in moving across multiple systems of care and then being connected back has been, those personal testimonies and walking us through those experiences have guided the work that we have done to continue to move us from coordinated care with behavioral health to really fully integrated pieces of the whole. Some particular board member projects have been, around these issues of healthy living. Biggest Loser projects and walking clubs within public housing complexes have been, really well received. I think these were some projects that board members worked, really participated in with staff, and so staff took their cues and their lead and really benefited from the door opening that happened from our board members. And then our Health Unites Generations program, our HUGS program, is actually operates within the public housing complex and provides an opportunity for seniors within the public housing complex to connect with young people, to explore the issues of cross-cultural, around cross-generational issues of culture, as well as cross-cultural issues, because we have such a diverse community of residents in public housing, and they've been terrific about sharing that experience with the young people. And then using their feedback and participating in a senior prom, where the seniors from the public housing building participated with the teenagers from our local high school and held the dance that was the senior prom. And again, I think these activities would not have been possible without that connection of our board member and the door openers to public housing and to the housing authority in particular. And so that's the end of my formal presentation. I'm certainly open to conversations and questions from some of the aspects that we talked about today. So, Devin, I don't know if we are able to open up for questions.
Thank you very much, Alison, for this wonderful presentation. We are going to start the Q&A session. If you would like to ask the presenter a question, please submit it through the question box on your control panel, or if you are dialed in through your telephone and you would like to ask Alison a question, use the raise hand icon on your control panel and your line will be unmuted. While we wait for some questions, I would like to ask all attendees to please complete the post survey that helps us with the webinars and the information that we can provide through our webinars. Okay, we have one question. How do we keep board members engaged throughout their terms?
I think that's a great question, and I spent a lot of time thinking about what are those strategies, because there are, we've absolutely had board members ourselves who had their participation ebb and flow. One of the things that we do on a regular basis, and I'm sure many of you do as well, is the board member self-assessment. And so really asking them the question about ways that they would prefer to be involved or are looking to be involved. It was helpful for us to then help think about ways to do that. We've also really often connected our board members to our coordinator for volunteer services, because we have a number of events that are happening, and they often need just a little bit of time, though some of them certainly have much bigger opportunities for an investment in time. So asking the question of the board members, and I think sharing with them opportunities to volunteer within the health center that you've already defined, that they can see, oh, I can do that, or I have time for a piece of that. Those have been things that we've certainly utilized to our advantage in the past.
Thank you very much for that information and that excellent response. There is another question that I see right now is, do you have any tips for training new board members?
You know, I think that one tip is that it's not a one and done opportunity. So, you know, we've really worked on a many-month process for that. The creation of a board binder has been really helpful because I think we do this to employees too, which is we give them so much information in such a short period of time and then think, well, surely you must have gotten all of that. You sure could digest this 2-inch binder worth of information. So being sure that we provide that to them so that they have a resource to go back to has been helpful. And the other thing that we've done as a part of board orientation is to have other board members orient new board members, because as much as we have so much we want to talk about from the health center perspective and, you know, boxes we want to check off to be sure we've covered, the most meaningful part of that orientation has often come from the chair of our board, Alan Steiner, who does a terrific job of really talking about the role of board members, the way he's been involved, and what that has looked like over time. So I think that, you know, those two pieces in particular have been a resource for us.
Great. Thank you very much. And I see one more question. Do you have any suggestion for how to develop useful CEO or executive director board? I'm sorry, CEO and executive director and board relationships. Basically, the question is how to develop useful director and board relationships.
Sure. You know, I think that this is such an important part of the success of the health center is that relationship. And, you know, sometimes it boils down to time and the ability to spend time with those board members outside of the board setting to really understand their priorities. We start to do that process when we're exploring adding new board members to the board in general. And the other thing is, I think, finding really concrete ways to encourage the participation of board members in the board meeting. Again, we have fallen victim to this more than once, where we have such a tremendous amount that we want to move through. We don't often leave as much time for discussion or to pose open-ended questions for the board to respond to. But when we're able to do that, and we do it consciously, the board members are able to really share their priorities, their concerns, and then the CEO and the team throughout the health center can respond to that. And I think you know, those have been, you know, really valuable ways to facilitate that. But again, if you open the floor and you have those conversations, you really need to be prepared to make a commitment to hear that and to respond to it in very concrete and clear ways, because I think nothing could sour the relationship more than asking for feedback, hearing it, and then not doing anything about it. So it really is opening the doors for communication and then finding ways to respond to it, not because we can do everything that board members have put forward, but the thoughtful consideration of their recommendations is so important, and for them to understand what the barriers were if it's not possible.
Great, thank you very much. And I don't see additional questions. However, I have a question for you. When I was listening to your presentation, the new pin basically says that you need to have a representation from all the special POPs that you serve. Mm-hmm. Now, if you have more than one, let's say that you have 2 or 3 special populations, is there any formula or any way that you allocate the number of people representing those special populations?
So there's no guidance to how to do that specifically in the PIN. It does say that for every stream of funding that you have, you need to have at least one representative that represents that special populations. So, again, I think that there's so many factors that go into decision-making about how the board is represented. If you're a one or a two location health center and both of those are located within public housing complexes or adjacent to them, then that percentage might be really high. If you're in a dense urban area and you have both homeless dollars and public housing, but you also have a significant population of folks who are general community users, community health center patients, 330E, I think the breakdown across that really comes from looking at your UDS and understanding where your patients are coming from so that the representation feels representative. And I think that our UDS data can give us some ability to think about appropriate percentages and proportions to be sure that the board feels representative.
All right. Well, thank you very much. I want to thank one more time Allison for her time on this wonderful presentation. Thank you very much for keeping us abreast on board governance. And I would like to one more time remind all of attendees to complete the post survey. This helps the National Center for Health and Public Housing to improve our webinars. Thank you. And if you have any training or technical assistance needs, please contact any of our staff members. Once again, you can also find information if you visit our website, www.nchph.org, where you can find information about this and other webinars, monographs, training manuals, newsletters, information about our annual symposium, and information on one-on-one training. You can also join our mailing list and receive updates, Medicare updates, information on funding opportunities, information about senior programs, and information about webinars. You can also follow us on Twitter, and you can subscribe to our YouTube channel. Very much for attending this webinar, and thank you, Allison, for your time.
Oh, you're welcome. It's my pleasure.